So first of all, good news. It seems that we're back on time. So we do have 25 minutes for discussion, and we've already received several questions from participants. Please, of course, if you have other questions or comments, do not hesitate to send them via the chat. So maybe I will first ask you a couple of questions that were addressed to specific speakers, and of course, if anyone else on the panel wants to react or add anything, feel free to speak up. So first, there were a couple of questions for James following your presentation. Well, two questions specifically regarding the UK healthcare system. So the first question would be to what, and that ties with Priscille Sauvegrain's presentation. The first question has to do with the extent to which there is racism in the UK healthcare system, or any overt or actually unconscious discrimination towards certain populations. You talked about differences between general practitioners and specialists, but I think the question is a little bit broader than that, and asks whether there's evidence of racism in general. And the other question that's related to that is essentially whether, so either yes, there is racism, or if there isn't, does that also mean that persons who are white but have low income or low educational level also can also have poor access to healthcare, and what is the weight of social determinants versus ethnicity and race?
Thank you, Maria. Two interesting questions, and two questions actually which connect very well with the talks that were given by other people in this session. You know, the question of implicit attitudes, unconscious bias, and explicit racism, and the ways in which people are treated explicitly within healthcare systems. Are healthcare workers as racist, more racist, less racist than the rest of the population? I don't think we have a clear answer to that question, but it's clear that there is racism within the different healthcare systems and in the treatment of fellow workers in much the way that Francesca was describing. So there's been big studies of where ethnic minority people sit in the hierarchy of the NHS in the UK, and they echo very strongly the things that Francesca was saying. There's also been studies of explicit and unconscious bias, which echo some of the things that Priscille was saying as well. So racism is there, and we see it in the outcomes. So I focus very much on the outcomes, and we see it in the outcomes. Yeah. So maybe I won't say more than that, just so we can have a bigger discussion in relation to that. In relation to white working class people, in the politics of race within the UK, the discussion of white working class is often used to distract attention from questions of race as being, or ethnicity as being a driving force of inequality. Look at the white working class and what's happening to them. This is not about race or ethnicity. The white working class are just as poorly off. And that both racializes and classes white people in a very particular way. And of course, we have very marked class inequalities in the UK as elsewhere. These relate to infrastructures around us, including access to primary care and secondary care. And of course, people are treated differently according to their class. Again, this connects with some of the stuff that Mathieu said. You know, people are treated differently according to their class and gender and so on, as well as according to their race and ethnicity. For me, the crucial thing here is, why are ethnic minority people more likely to be in adverse socioeconomic circumstances? And then you have to think about explanations related to race and ethnicity, like racism.
Okay, thank you. Is there any reaction of anyone else on this topic? There was actually another question which ties into this as well, which is about intersectionality and the extent to which there is evidence that cumulative disadvantage can actually explain some of these mechanisms. What's also very interesting, of course, is that the groups that may be at highest risk of poor health outcomes in the UK are not the same as in other countries. You know, of course, particularly in the context of the COVID-19 epidemic, we know that there are huge ethnic and racial disparities in mortality in other countries, in France as well as in other countries. But the groups that are at the highest levels of mortality are not the same as the ones you showed for the UK. In France, it will be people from sub-Saharan Africa mostly, but of course they're probably experiencing the same forms of disadvantage as what you showed for the populations that originate from Bangladesh and Pakistan. But anyway, so the question was about cumulative disadvantage and how you actually test and see the contribution to the health disparities which you showed.
Yeah. So Maria, if I could just pick up that first point, I think that's a crucially important point. Actually, Black African people in the UK also had very adverse outcomes in relation to COVID-19 mortality, but that's not the point I wanted to make. The point I wanted to make, of course, is that there are histories behind this, which then lead to particular processes of racialization, which then lead to potentially different situations in different countries, which is why international comparisons are both very, very interesting to do, but also quite difficult to do unless you embed that context and that history in the work that you're doing. And then the question of intersectionality, which I'm imagining others may also want to talk about. But intersectionality, it at one point describes something, it's descriptive and pointing to some fairly obvious issues. The way in which a black woman is treated will be different from the way in which a black man is treated. The way in which a Muslim woman is racialized will be different from the way in which a Muslim man is racialized. So gender comes into play, and then you can also see how class might be as well. So I did a report in relation to COVID for the Greater London Authority, where we looked at a whole range of what in the UK we call protected characteristics, things like disability, gender, age, ethnicity, religion, and so on, and showed disadvantages happening across all of these dimensions. We didn't quite do the summing up of those disadvantages, which might be the quantitative approach, but rather looked at how modes of oppression operate across these different dimensions. So focus on modes of oppression, patriarchy, racism, misogyny, and so on, and how these operate jointly. And I think it's maybe slightly wrong to think of this as let's add gender to race, to disability, to sexuality. Rather, let's think of how for an individual or a group, different modes of oppression interact to produce an adverse outcome. And if you look at the kind of COVID mortality stratified by gender, you see that race is a driving factor. But that doesn't mean that race operates in the same way or racism operates in the same way for men and women. It's not a very clear answer, but I'm more interested in the modes of oppression than in the intersectional identity of an individual.
Okay, thank you very much. That was very, very clear. Does anyone else want to react to that question about intersectionality and where that helps understand some of the patterns, or maybe it's not the right way to look at ethnic and racial disparities?
Well, maybe if I can quickly intervene, I was struck in James's presentation in one of the graphs showing the health, perhaps the percentage of poor health by ethnicity, and perhaps it was like income quartile or tertile or something. And it looked like the way socioeconomic circumstances as measured by income negatively impacted health differed by ethnicity. And specifically, as far as I remember, it tended to show that the bottom and middle quartiles among Bangladeshis were very similar, as contrasting with the big differences among other ethnic groups. So I was wondering if that's something that you saw too, and whether there are interpretation on how class might work differently among Bangladeshi compared to other groups.
There's a problem with co-presenting with a bunch of sharp-eyed colleagues, isn't it? That they see things in your data that you slide past and gloss over. So clearly, at the higher level, thinking about these as theoretical concepts and the ways in which they shape our lives, class will operate differently for different ethnic groups, or ways, and the ways in which gender operate, and so on. Absolutely. I think the detail that you saw in my slide is really I have argued, a reflection of the inadequacies of the single measures of socioeconomic position that we use. So, for example, I have a chart that shows that for a particular class location, income varies dramatically by ethnic group. So if you control for the class, you're not really controlling for very much. And similarly, what you can buy with your pound varies dramatically across ethnic groups. And so what you need are more complex measures of socioeconomic position. And when you start using those, you begin to do a better job at explaining ethnic differences in health and in showing the gradient of health inequality within an ethnic group. So, yeah.
Thanks.
Okay.
So I think the broader point about the ways in which class, gender, etc., operate differently in different locations, I think, is an absolutely important one, and one where there is not, I think, sufficient investigation, theoretical or empirical.
Okay, thank you. Are there, Francesca, Priscille, anything you want to add?
Francesca, I think.
Just the intersectional approach I wrote in the chat emerged as a key issue during my fieldwork. I didn't plan this kind of approach before going on in the field. So it was really an evidence that Black women were discriminated more than white, more than European.
Well, if I may add something, for me, it's a way to put my results at the macro-social level, because, for example, like most of African women I met in my last research, not BIP, but the previous one in 2016 to 2017, they had more envious positions in Africa than they have now in France. So there's elles subissent vraiment un déclassement professionnel. And this figure of the African mom is really much found at the macro-social levels, because they are taking charge of our children and of our elder. And they are cleaning our let's say, in the best case, houses with declaration, and in the worst case, in the morning and late in the evening, how the big sofas, blah, blah. So it's really, for me, it's a way of linking all these results. It's a microsocial effect, it's a mesosocial effect. The hospital is quite protective, but not enough. And we have also a huge issue at the macrosocial effect.
Okay, thank you. Thank you so much. What was really interesting in your presentation, Priscille, was also to talk about positive stereotypes and the ways in which they can, I mean, although they're positive, they can also actually have perhaps negative consequences, because they're still stereotypes and don't make it possible for women to actually well, be treated in the same way as women from other groups. So there are also a couple of questions about the Mathieu Ichou's presentation. One is they're both sort of technical, but I think it's important to clarify these aspects. So the first question has to do with the types of foregone care, which you've studied in your presentation. I'm sorry, in your paper. So did you actually look into whether people were foregoing GP care or specialized care, or were there were there particular areas where there was a higher likelihood of foregone care? And the other aspect is, it's a question about the types of comorbidities and aspects of health. I guess, well, that's sort of obvious, but if people are healthy, they may not need to go to the doctor, and then they don't know if they would be discriminated or not. So can you please clarify that?
Sure. So thanks for the question. Actually, we did not distinguish between different types of care. So it's overall foregoing of overall care, although indeed it would be a very interesting distinction to make, especially perhaps between, well, outpatient and inpatient, but also between different kind of doctors, potentially, GPs and specialists, Well, I mean, it's not something we explored. I guess there might be sample size issues, obviously, but thanks for the suggestion. As for what type of health status variables we included basically what was available in the TEO survey, which is not a lot, but something. The main one was basically self-rated health. There was also a question on previous chronic illnesses. And there was a more direct question on how many times the respondent, went to the doctor or other healthcare facilities in the past 12 months. So it was all indicators of exposure to the healthcare system and therefore to potential discrimination within it.
Okay, and the question that follows from that is, how about TEO2? What types of health questions or healthcare access questions were you able to include?
So TEO2, we more than doubled, I think, the amount of questions in the health module. We included the additions are multiple, and I won't have time to go through each of them. But one thing perhaps I can specify is that we added a question on mental health, and I think that might be especially interesting in the context of studying the effect of discrimination on mental health. But there are a lot of other additions, and stay tuned on the TEO2 front, because there will be great data available next year.
That's great. That will be a great opportunity to document certain phenomena, which I think it was mentioned in the chat among the questions, but also in your presentations. We still really lack data and objective information about these topics in France, and that just leads way to unfortunately many interpretations that are far from the truth. I don't see any other question. Yeah, sorry, go ahead.
Yeah, could I just add something to the last question? I think type of care foregone is a really very interesting one, and I fully appreciate it's so difficult to do, even if you have a very large and very impressive quantitative survey, it's so difficult to do. But the kind of, in the UK context, and it may well be similar in France, in the UK context, something like care for severe mental illness is routinely foregone. So there's lots of discussion about delayed presentation without much thinking about why there is delayed presentation. And of course, we have long experience of Black patients being treated very poorly within mental health institutions, and of deaths within mental health institutions. And in that context, both carers and the cared for will be reluctant to seek care. So there's also the kind of very active discrimination that happens when you go for care, and so the maternal stuff. I mean, it's shocking in the UK. I didn't realise that there were issues underlying that also in France. And
yeah, so if I can add something, we do actually have data on psychiatric care among migrants in France, which also shows that, at least in Paris, but that's where most immigrants are. So we don't have data about people who would be, members of ethnic minorities that are not, but not immigrant. But there is evidence that they do get later care and also more care. They also they get more constrained care, if that's the proper right institution, and less follow-up care after hospitalization. And there's also a lot of data in France about social determinants of access to healthcare, which shows that where there are experiments among people, so experiments where people try to get access to care under different scenarios, and there's a lot of evidence that in the private care system, which is quite large, having certain types of health insurance which are incomplete, and when you're not able to fully pay for the appointments, etc., physicians and dentists are more likely to actually refuse care. So that's been very widely documented, not specifically for migrants and ethnic minority groups, but because they tend to have lower income and lower socioeconomic position, they are more likely to see actually healthcare being refused because of socioeconomic issues. But yet, hopefully that's also an area where TO2 will help provide strong evidence. So I don't see any other questions in the chat. If we do have a few more minutes, so I wanted to ask you something as the epidemiologist on the panel. I have a question, and I saw you use different types of methods. My question is more about what do you think about the ways of measuring discrimination? It's such an important topic because, of course, people may not feel that they're discriminated. That's been widely documented. Or they may have the impression that they're discriminated for some other reasons than their ethnic origin, or to the contrary, they may have, well, anyway, there may be different reasons for differential type of care and such issues. So I mean, of course, you've used different methods in the different data that you presented. Does anyone want to react to that, to the issues of measurement and how they can impact the data, how they can, what could be done in future research?
I'm happy to begin, but I'm conscious that maybe I'm taking up a lot of airspace. But some time back, a colleague of mine and I, Stefan Carlson, wrote a book on measuring race and racism. Not a book, a chapter on measuring race and racism, where we began to explore some of those issues. But I think working with other colleagues, my thinking has moved on a little bit. So it's hard to measure. Of course, it's hard to measure. And if you want to measure the kind of structural and institutional processes, which I'm also interested in, that becomes really difficult. But for interpersonal racism, we've, again, another colleague of mine, Laia Bakaras, has kind of moved us towards thinking about measuring experiences of racism across the life course, but also thinking about interconnected experiences of racism. So the racism that your partner experiences, or your mother experiences, or your friend experiences. Long way around of getting to the question of the evidence that we've looked at suggests that you should ask about racism directly rather than ask about discrimination and then ask what's the reason for it. If you ask about racism directly, you identify higher rates, and we think that's probably closer to the truth. Also, that you should try and measure it in different domains of life. So what happens in your workplace, what happens in education, what happens when you're going shopping, and so on. And thirdly, that you should try and measure it at different points in a life course. So what happens when you're a child, and so on. And the argument here is about accumulation of disadvantage. So trying to measure accumulation of disadvantage across domains and across a life course. And some of the longitudinal work we've done has shown that the more experiences of racism, the greater the impact on your health. So you can see a kind of almost dose-response effect. So a partial response to your question, Maria.
Thanks. Yeah, thank you very much. Does anyone else want to talk about that, about questions? I don't know, Mathieu, how did you go about measuring discrimination in the TEO study, and what were the sorts of issues you faced?
Well, so I think the sort of both the difficulty and the opportunity with measuring discrimination and racism is that there are several levels, as James pointed out. There's the structural, institutional, interpersonal. There is what happens, and there is what it is, and categorized as an experience of racism or discrimination. And so my sort of empirical approach would be to advocate for a pluralistic approach to measuring discrimination and racism. We know that it's a complex and multidimensional set of phenomena, and so we should use different indicators. There is no one single best way of measuring. And so the approaches that center around, like the one I used, center around self-reported discrimination are very important, because whatever happens is what you believe happens and what you perceive that also has real life consequences for you and those around you. But other ways of measuring, such as experiment-based or audit studies or these kinds of things are also valuable in some settings for hiring situations or for in the housing market, for example. And yet again, the more sort of regression-based residual way of measuring discrimination, where you compare people with similar levels of education, similar level of professional experiences, and then you find that, oh, those are paid less than people exactly the same of a different skin color. This is a third, and this is very classical stuff, what I'm saying, but I think instead of making one compete with the other, it's just good to understand that they measure different things, and we should keep measuring different things, but trying as much as we can to combine these different approaches.
And how about covert discrimination? Priscille, can you maybe talk about that?
About
well, unconscious patterns of
well, it's really interesting, this implicit bias studying, because they were first explored in the employment, and now I was really thinking about, is there common stereotypes? I mean, because we are working at the hospital and we are supposed to leave our opinion at the door of the hospital, but it's also a social impact. So is this implicit bias really constructed during the studies, during the medical practice, blah, blah, or is it from education? Is it from your family? What is the return of the implicit bias? Because I mean, a lot of studies, they are studying the implicit bias from white people to black people. But what is the others? What is the return implicit bias? And so it's, you know, it's many things putting together, and now we have to explore this in a meticulous way to establish this. But I'm certain, because it's my experience, that you are arriving at hospital, and if every single day you heard, oh, African women are so late, it's not in their culture to be on time, at the end, you believe it. And if once you read a paper explaining that the farthest you live from the hospital, the less money you dispose to take a taxi, and then you have to bring your children at hospital, and it's why you're more late than the others, you understand, wow, I'm believing something for around 5 or 10 years, and it's just completely wrong. So it's why I'm really realizing in education.
Okay, that actually ties with the last question, which we got, and we have 4 minutes left, so it will have to be a quick answer. But the last question has to do with how to make things change at the institutional level, and how to make different actors, maybe in the hospitals, and even further, actually become conscious of some of the issues of racism and discrimination that go on. And you know, how do you see your research having impact? It's a very broad question. I'm sorry. I don't know if anyone wants to take that up.
So first of all, we discussed about studies in France. Ethnographic studies of hospitals are looking at caregivers as white people. So first of all, I think we have to study these new configurations of being a caregiver. And second of all, but that's an idea. Let's say everybody can put an idea. This is the first one. And also, because also the interethnic minority relationships, they are very present actually in the hospital relationships. So they may have impact also, and we don't know a lot of things about that, because it's also a racism un racisme interminoritaire, sorry. Et donc du coup, ça doit être aussi vraiment étudié maintenant, je pense, beaucoup plus.
Okay, thank you, James. Do you want to add anything?
I'll add a little bit. I mean, I think so. I think Priscille's work on implicit attitudes, on unconscious biases, is crucially important. But I think, as Mathieu said, it's only part of the overarching picture. And so, within the UK context, unconscious bias training has become very important and very popular. And a number of institutions are doing that, including universities are doing that. And we all know the example, again, thinking of what other people said, Francesca's, that picture of the surgeon doing the quadruple bypass and then being asked to go and get a cup of tea. We all know of these experiences where the black female academic walks into a room and someone turns to her and says, can you fill up my tea or my coffee or whatever, you know. And so that unconscious bias training is most definitely a way forward, but we also need to couple that with more conscious strategies to address racism within institutions. And part of that is about our role within institutions. We are active within institutions. And so in the University of Manchester, we have this bystander program where basically you call out racism when you see it. You don't let it pass. How effective it's going to be, I don't know. But so that training to remove the stereotypes or to try and remove stereotypes from our head, as well as the conscious active challenge, is crucially important. But more broadly, I think we need to think about how institutions have different functions, and then we need to think about how we shift how they approach those functions. And that really requires leadership at an institutional level. In the current context, in the Black Lives Matter moment and in the COVID-19 crisis, many institutions are talking about doing that. And I think we just need to continue to encourage them to do so, to present them with the evidence, and to campaign in these areas and to support campaigns in these areas.
Thank you very much for this very inspiring conclusion. I'm sorry we have to stop here, but I certainly hope that many French leaders heard you, and many French doctors and hospital directors. I think we still have a long way to go, but it's really great that we can also share experiences with other countries and have an idea of how things could be done. So thank you all for great presentations and a wonderful discussion. I'm sorry we didn't have time to cover all the issues that your presentations brought up, but I hope we'll have other opportunities to discuss your research and issues of racism and discrimination with regards to health and access to healthcare. Just before we leave, I want to remind everyone that we now have a break and that the next session starts at 2:30 and has to do with migrations and empires. So it's run by the Global Department, and we'll talk more about the history of migrations. Thank you all once again, and it's been a pleasure to listen to you this morning. Bye-bye.
Thank you very much.
Bye.
Bye, everybody.